A very good evening to each one of you joining with us today, and a distinctive reception to you, Dr. Ruhan. Thank you for sparing your precious time to be with us, that too this late on a Saturday evening. We are very pleased to have you on board.
Thank you so much, Dr. Aditi.
Yeah. So for our viewers, ladies and gentlemen, Dr. Ruhan is a practicing pedodontist, and she's currently running a private practice in the golden city of Amritsar. And you must take my word for it, like kids love her. And she makes the procedure so seamless and fun that it hardly is a thing for the kids. And today she'll be sharing her wisdom with us via her webinar, Treating the Primary Incisors. And I'm sure that we'll definitely get a hang of it, and we'll learn how to add smiles to those, how to add shine to those tiny smiles. So, ma'am, we are good to go. We can begin with our webinar.
First of all, thank you, Dr. Aditi, for penning down such lovely words for me. So, can I share my screen now?
Yes, ma'am, you can. Yes.
Okay. Good evening, all present. I'm Dr. Ruhan, and we'll be discussing some things about primary incisors. So why I've chosen this topic, it's because, if you see so many children around in your practice as well, you'll always see one or the other incisor, primary incisor caries. But we often neglect it. Not we, but their parents also. Because it is often said and seen that these incisors, they fall off so early, so why to treat them? But no, that is not the deal. Why to give that child a presence which is not liked by anyone? No adult, nobody is interested to have such black spots on their permanent teeth. Why the children should face these? So today we'll be treating primary incisors. So let's learn how to add shine to those tiny smiles. So when I was preparing this seminar, I was looking for the quotes. The best quote I could find was this one. The best feeling in the world is knowing that you are the one who made the baby smile. Yes, it is indeed a very good feeling. And anybody who's practicing pediatric dentistry or general dentistry in that matter and treating children would surely agree to it. So the contents will be just a little bit about the stages of caries and incisors. So these are basically stages of early childhood caries, but we'll just be talking about what the impact is on the incisors. Then we'll be learning detailed in management of the each stage. And then in the end, we'll be just having a summary. So these are the stages. First is the initial reversible stage. So the initial reversible stage is the chalky white discoloration that you often see on the primary incisors. Often see, but yes, often missed as well. But these, if you can diagnose it, you can treat it there and then. It is a reversible stage. So you can maintain the teeth in that position and in that shape as it is. The next we have the damaged carious stage. These are the yellowish brown discoloration with cavitation, and you can see clear dentine involvement. It can be asymptomatic, or the child may feel sensitivity to cold. Then we have the deep lesions. The deep lesions, they are in these cases, we often see in radiographically that pulpal involvement is present in incisors. They can be symptomatic when the incisors are already necrotic, or they can be really painful. The last one is the traumatic stage. In this case, we have the teeth which are weakened by caries, and they often get fractured on minor traumas. The maxillary incisors in these cases are usually non-vital, and pain may be present if there is any abscess, or they can be totally, completely asymptomatic. Moving on quickly to the management of the incisors according to these stages. So first one is the initial reversible stage. So if you can see this white line over here that is present, just along the gingival margins, this is what we call as the white spot lesions on or the incipient caries. These are the earliest clinical signs that can be seen in a child's mouth, especially in cases of ECC. And these white spot lesions, they can be clinically defined as a white opaque area due to subsurface mineral loss occurring below a relatively intact enamel surface. So what does this actually mean? This actually means that the topmost layer is usually intact and the layer underneath it, it is usually, the enamel prismatic structure has been destroyed. So because of that, it is very difficult sometimes to, diagnose it. So how to diagnose it? The best way is to dry these teeth. Dry the teeth with the 3-way syringe, and these lesions which immediately appear very dull, very rough and opaque compared to the normal enamel, and then you can immediately look at it. So this stage, how you can proceed with the treatment, because it is a reversible stage, so we need to do things which can reverse these lesions. So first is fluoride varnish, and second is ACP CPP fluoride varnishes. Now let us take one by one each of them. Okay, the fluoride varnish, it is the most commonly used agent for professionally applied fluoride treatments. So the fluoride varnish that is generally used is 5% sodium fluoride varnish, and just take it a note that it is something wonderful. If you use it, if you apply it on the teeth, you will see changes within months. The lesion will reverse, and it is so effective that children. It is so convenient for you to apply, convenient for the child, convenient for the parents, hassle-free, and it's just a magic when you have to apply this varnish on child's mouth, and voila! It's just voila! You see the change right there and then. The fluoride varnishes are the only professional topical fluoride agent that are recommended for children younger than age 6. So we have other fluoride agents as well, as if the APF gels, other things also. But the fluoride varnishes are the only they are only recommended for the children below the age of 6 years, because you have to apply the fluoride varnish just like you're painting something, you just have to paint it over the teeth, and there is no overflow of the fluoride varnish. While in gels, there can be overflow and children can ingest it, because children younger than 6 years old, they do not usually know when to stop ingesting. So it is better to go for fluoride varnish, which will not lead to any fluoride, side effects. So now talking about a little bit about the mechanism of action, I won't go in much detail. So why it is important, what does it actually do? So fluoride has dual mechanism of action. Firstly, it causes remineralization. How does it cause remineralization? So if we have a crystal, if we look at it, if we see it as a tooth, whenever there is a pH fall or there is acidic medium in the environment, obviously there is demineralization. So in the presence of fluoride, there is formation of fluorapatite, which is, first of all, it forms faster. Second of all, it does not dissolve as easy as the normal carbonated fluoride. This is how it causes remineralization. And the next one is preventing demineralization. So whenever there is a pool of fluoride present around the tooth structure, what it does is it completely covers the tooth surface like this. It gets embedded on it, right? Whenever there is acid attack, the fluoride won't allow the acid to, demineralize the tooth structure. Wherein if there is less of fluoride present, it will lead to partial coverage of the tooth surface, and it will eventually lead to the demineralization of the surface layer. Next is the CPP-ACP varnish. Basically the mechanism of action is similar. The presence of CPP-ACP in the medium in surrounding the tooth structure, it leads to the excess of presence of calcium and phosphate, which gets attached to the biofilm. And whenever there is acidic medium, it won't let it gives you a major pool for calcium around the tooth surface, which helps in remineralization of the tooth structure faster as compared to when there is it is absent, calcium and phosphate are absent over here. Basically, CPP, what CPP does is CPP, it is a layer which can bind the ACP particles, acylated calcium phosphate particles, onto the tooth surface. Now, the clinical usage, how to use all these varnishes. These are the steps. These are the basic steps which which are as easy as applying a nail paint to your nail. So what you have to do is you just have to dry the teeth and you need to isolate them. Usually it is done with gauze piece, and it is better that you isolate the teeth quadrant wise, because it is easier to manage little bit of teeth rather than managing the complete teeth at a go, complete arch at a go. So after drying the teeth and isolating them, you need to apply the fluoride varnish. How it is done? So you just need to apply the fluoride varnish with the brush that is being given along with the varnish, and you have to apply a thin layer on all the surfaces of the teeth. And application time is at least 4 minutes. That is, you have to isolate the tooth for at least 4 minutes. And after this is done. That's it. That is what you will be doing in your first sitting. And then after every 3 months, you need to repeat the application. That's all you have to do. It acts as something which can prevent the occurrence of caries, as well as which can reverse the reversible white spot lesions. So now, after applying fluoride varnish, what instructions you have to give to the parent? First is, the child is not supposed to eat for 1 hour. The next is, you eat only soft food at the next meal. And you need to avoid sticky foods for the rest of the day, like fruits, toffees, gums, anything like that. And lastly, don't brush until the next morning. These are the 4 instructions that you need to give to the parent, and you must give it. Usually we forget it, but you don't have to forget, you need to give them. Next is the damaged Carious stage. So how to diagnose it? It is a yellowish brown discoloration with cavitation. So you can see here this spot, a yellowish brown discoloration with which you can see the dentine and enamel is completely broken from here. Usually it is asymptomatic, or if the lesion is big, it can be sensitive to cold. If dentine tubules are exposed, obviously it will be sensitive. And IOPRs, the lesion is limited to dentine, and it is not involving the pulp. So treatment here, what you can do is, you can go for intracoronal restorations. Like in this case, the picture that is being shown, you can go for class 5. Or you can go for silver diamond fluoride activation. Or the other thing that you can go for is smart technique. What is it? We'll just talk about in later slides. And the treatment, these 3 treatments can be selected depending on the child's cooperation and age. What does that mean? If the child is uncooperative, or if the child is, maybe 1.5 or 2 years old, it's very difficult to treat them with restorations. You can always go for STF application, which is very simple. Child cooperates with it, and so it's easy. So you can go with it, and child be more comfortable. Whenever a child then is of an age where he can cooperate with you, you can then go for the restorations. Talking about the intracoronal restorations. So here the class 5 restorations in primary teeth are exactly like what we do for the permanent teeth. Like excavate the caries and making slots in gingival or cervical segments or grooves, and then filling it. So it should be extended beyond any cervical decalcification. So all the margins should be covered. The margins should lie in the intact tooth structure, and you need to give your undercuts or retentive grooves incisively and gingivally, because it will enhance the retention. Then the aesthetic materials obviously have to be used, which can be glass ionomers, compomers, resin reinforced glass ionomers, or composite resins. Talking about the class 3 restoration. The class 3 restorations of primary incisors is challenging. Why? Because first of all, talking about general anatomy of primary teeth, they have really large pulps. So first of all, talking about incisors, they are just too small. Pinnacle crown is really small. Then they have really large size of pulp chamber. So the proximity of the pulp horns to the interproximal surface, it increases. So it is really very difficult to do class 3 restoration without exposing the pulp chamber. Therefore, it has been recommended that even small class 3 restorations in primary incisors have a labial or lingual dovetail or somehow incorporate a large surface area for bonding to enhance the retention. How can it be done? I'll just show you. So these are various type of restorative designs which can be made, including the first one you can see A, it has slot preparation with a dovetail. So this is dovetail which is seen on labial surface, and there is a slot preparation. This will obviously give additional retention. Then we have in B, we just have a slot preparation. Slot preparation because it is a small restoration, so it will suffice. Then we can have a modified version of the slot preparation, which can include the cervical lesion as well. So this will give the class 3 restoration more surface area to bind it. Then lastly, we have the interproximal box that can be created, which is perpendicular to the line of tangent to the labial surface. This one, perpendicular to it. Now we are done with restorations, coming on to something easier and something children like to get treated with. These are the thing is silver diamine fluoride or STF. So to do it, the most important thing is to select the tooth, because selection of tooth will tell us whether the STF treatment will give us proper results or not. So first of all, there should not be any clinical signs of pulpal inflammation or reports of spontaneous pain. This is what we see clinically. So there should not, the tooth should be intact, totally asymptomatic. The cavitated caries lesion that are not encroaching on the pulp. So radiographically, we should not see that the lesion is encroaching or involving the pulp. And the STF can be used prior to restoration placement as a part of caries control therapy. The STF can also be used just for, because especially in ECC cases, when we see there are multiple teeth that have to be treated. So it's better to put STF before you start with any other treatment, so that the caries, it stops there and then. So before telling about the steps of application, let me tell you what STF does. STF basically, it is silver diamine fluoride. What it does is the silver present in it, it blocks the, it is toxic for the microbiome of the lesion, and it stops the caries there and then. And fluoride that is present it helps in remineralization. So steps of application of fluoride are, STFR, sorry. So first of all, you need to remove the gross debris from the cavitation. Then you have to apply protective coating on lips and skin to prevent temporary discoloration. So STF, it causes real discoloration to the cavitated portion, like the teeth turn completely black. So here, when you apply STF, it can also cause temporary tattooing on the lips or the gums around it. So what you can do is you can always apply some petroleum jelly on the surface, so that the lips and skin and all the soft tissues, they are protected. Then you need to isolate areas to be treated. And next you have to apply the STF with microbrush, and for the entire treatment, you do not need to take more than 1 drop of STF. For the entire appointment, you should not take more than 1 drop of STF. Then you have to dry the lesion, and the application time should be at least 1 minute if possible. If possible, because when you're treating small children, it sometimes is not possible. So you should try that at least 1 minute application is given by isolating. So this is how the SDF looks like. It turns the teeth completely black, and also the gums that are present. You can see over here, they are temporary staining of gingival tissues. You can see these can also happen. It will, you can tell the parent that it will just wither off with time. Within a week, it will just be normal. Next is the smart technique. So sometimes what you see is a lesion which is this small. Okay, so you need to apply SDF, but parents want that we don't want the dark discoloration. So what you can do is you can just perform the steps of SDF application, and you can just put the GIC on top of it. That's it. It will cover, and the teeth will be restored. Just like that, you don't have to drill, you don't have to do anything, you just don't have to remove the caries. You just have to apply the SDF and the glass ionomer cement over it, which is called as the smart technique. Smart technique is silver modified atraumatic restorative treatment. So atraumatic means you don't have to really remove the caries. Okay, so talking about the pros and cons. First of all, it is minimally invasive. Of the smart technique I'm talking about, it is aesthetic, it is durable, it is biocompatible. Cons can be GIC alone may not mask the entire SDF plaster. Yes, I've seen in patients, I've myself seen in patients GIC, it might not alone mask the scar. The larger lesions may require a full coverage restoration like crowns. And smart is a treatment for cavities, and it is not a cure. So it is not a cure, you're just treating the cavities. Coming on to next are the deep lesions. In this, what you see is radiographically, the incisors, they are pulpily involved. And usually the patients complain of pain, but if the tooth is asymptomatic, then the tooth is necrotic, then the patient won't feel any pain and it will be asymptomatic. So how you can treat it? The endodontic treatment, which is pulpotomy or pulpectomy, obviously depending upon the upon initial and clinical diagnosis, followed by crowns. So whatever the indications for pulpotomy and pulpectomy, you need to apply them, and then you have to go for the desired treatment, followed by restoration with a crown. So endodontic treatment can be pulpotomy, can be pulpectomy. So let's look what are the indications for both. First of all, for pulpotomy, the caries approaching pulp, but no clinical sign of pain. So it is just approaching pulp. It is not involving the pulp. Mind it, it does not involve the pulp. It is approaching the pulp. There should be around 1 mm distance between the lesion and the pulp. That is what, and that is when you need to do pulpotomy. Secondly, when you're doing pulpotomy, clinically what you have to see is that after removing the pulp from the pulp chamber, when you try to stop the bleeding, it stops within 5 minutes. If it stops, that means the radicular pulp is healthy and the coronal pulp is not healthy. So then you can go for pulpotomy. Otherwise, if the bleeding does not stop, then you'll go for pulpectomy. So materials that are used are formoprazole, biodentine, MTA. There are many other materials, but these are the most commonly used. So I have just written these. Otherwise, there are many other materials that can be used. Next, for pulpectomy, the indications are frank pulpal involvement. That means there is no demarcation between the lesion and the pulp chamber. The materials that are used are zinc oxide eugenol, calcium hydroxide, and iodoform paste. So again, these are the most basic materials that are used. There are many other materials that can also be used for pulpectomy. Okay, now just giving you a quick step-to-step procedure of how we do a pulpotomy. So first of all, you have to give the local anesthesia. Then you have to isolate the tooth with rubber dam. Then after that, you have to remove all the caries. You see a pinpoint exposure of the tooth, followed by complete coronal removal of the roof and coronal pulp amputation. And then you have to control the bleeding with normal saline for 5 weeks. If the bleeding is controlled, you can further move for putting the agents, the PULPOTOMY agents that are NTA, iodine, or formocrosol. Formocrosol, when put, it is just put on a drop is used. You on a cotton paget, just place it over the bleeding site for another 1 to 2 minutes. Remove it and place ZOE and see. So place the PULPOTOMY medicament after it and seal it. Next, the steps of pulpectomy. Same. You have to give anesthesia, you have to isolate, you have to open the pulp chamber. After that, whatever you do for root canal treatment, the procedures are the same. But with a twist that the material that you use, it is resorbable. Because obviously the primary teeth, the roots resorb, so the material used should be resorbable. So here what I have done is I have just amputated the entire pulp with the files. I have done the PMP. Then we are irrigating it. Then what we are doing, we are drying the root canal. This is the dry root canal you can see. And then we are filling it with calcium hydroxide iodoform paste. After that, you need to restore the tooth structure as well. So crowns after endodontic treatment are as follows. They can be open-faced stainless steel crowns. So this is a stainless steel crown which has a buccal surface made up of the tooth-like material. Tooth-like seam material. Then we have resin composite strip crowns. Then we can have polycarbonate crowns. We can have pre-veneered steel crowns. And then we have the zirconia crowns, the lightweight zirconia crowns. So let's talk about restoration with strip crowns. So strip crowns, first of all, although they are easy to use, but they are technique sensitive. Why? Because it requires complete isolation because we are dealing with composite. And next, they also require for you to choose the strip crown according to the size of the tooth, to prepare the tooth, and finally, you need to just see the seating of the strip crown onto the tooth. So how do you check for the size of the crown and the tooth? So you need to measure the incisor edge of the strip crown to that with the incisor edge of your primary incisor. Okay. So you need to measure that, and followed by it, you need to cut the tooth surface. I'll tell you what dimensions you need to cut. Followed by it, you need to place the strip crown, see for the fit, proper fit, and then you need to do a small puncture on the labial side so that when we put it, fill it with the composite material, excess of the material, it oozes out from it. And then you need to just place it, cure it, and finally the polycarbonate covering, you need to remove it with a blade. So these are the crown cutting dimensions for a strip crown. So you need to cut 1 to 1.5 mm layer from the occlusal surface, and then from the labial surface around 1 mm, and from the lingual surface around 0.5 mm. So this is how a triangular shape should be made, and you need to cut the cingulum as well to up to 0.5 mm. Now, if we talk about the restoration of zirconia crowns, here in zirconia crowns, what you need to do is that you need to first of all go subgingivally. You need to go subgingivally. In strip crowns, we did not go subgingivally, but in zirconia crowns, we need to go subgingivally. The fitting is as per the size given by the manufacturer, and you need to check the incisor edge of the teeth with that of the crown size, and you need to select whatever crown is is needed for your patient. Then you need to do the crown cutting, which is a little bit more than that of these strip crowns. Then you have to go subdentally, and you need to have a passive fit. Because strip crowns, you can press it, you can have a snap-like fitting, but for in these cases, in zirconia crowns, you need to have a passive fit because they won't seat it. They won't seat it if there is an undercut of, if there is the fit is not passive. The last stage is the traumatic stage. So the features are the teeth are weakened by caries. The fractures on minor traumas are very prominent. The maxillary incisors are non-vital, and pain may or may not be present. So pain, you may see pain or you may not see pain. It is just because of the asymptomatic nature. When the tooth is non-vital, the tooth becomes asymptomatic. The pain may occur or the tooth may be mobile, but there might not be any pain. So treatment which we can do in these cases is like post and core, which can be done after endodontic treatment. In cases where the root is intact, and I will tell you the indications of post and core as well in primary teeth. Then we can go for extractions, followed by prosthetic replacement, which can be either fixed, like Groper's appliance, or removable, like removable dentures. So let's take them one by one. First is post and core. The indications for post in primary teeth. First of all, one half of the crown structure is lost. More than one half of the crown structure is lost. Secondly, at least 1 mm of the tooth structure is visible supradentine. So this needs to be present, otherwise the post and core will fail. The requirement for post for primary teeth is that the post should be short, retentive, which is appropriate for primary teeth due to the physiological resorption that occurs. So the post that you use should be short as well as retentive. So these are a number of posts. I have just mentioned a little bit, few of them are mentioned over here. But if you want to read about more, you can go to this article and you can get your knowledge enhanced on the topic of post, because it's a vast topic in itself. So these can be gamma post, a half gamma post, then it can be a metal post, a composite post, fiber post, nickel post, alpha post, anchor post. So there are many number of posts. And these posts, gamma post or alpha post, these can be made at the chair side. And this composite post is just done with the composite that we will normally use. So now, how to place the post, what you need to do, and how it should be done. First of all, the intracanal post should be placed at a depth of 3 mm up to the cervical 1/3 of the canal to avoid interference with the resorption of primary teeth or the eruption of permanent tissue. And the level of the post placement is evaluated radiographically. The post should always be at or apical to the intercrestal bone level. So what does that mean? It basically means that the post, it should be at a depth of 3 mm up to the cervical 1/3 of the canal. So the post should not go up till the half of the root. So the root, it should just be in the cervical half of the canal, so that it does not interfere with the physiological tooth resorption. Then next, the post should always be at or apical to the intercrestal bone level when you visualize it radiographically. So what you need to do is, after obturation, you need to remove around 4 mm of the obturating material. Then you need to place glass ionomer cement, 1 mm layer of glass ionomer cement. Then you need to place the post, and over it you go for the core. This is normal. This is the same way as we do for the permanent teeth. But in that cases, we just leave 4 mm of the obturating material, and post goes more deeper. Here you just have to remove 4 mm of the obturating material. Next, we talk about if we go for extraction. Why we need to extract the primary incisors, in which cases we do that. premature extraction that I'm talking about. First is when there is root resorption or there is foci of infection which is impinging the permanent tooth bud and remaining crown structure is less than 1 mm. You cannot restore it. You need to remove that. The extractions that are done that they can be followed by either fixed or removable prosthesis. And the prosthesis is only mandatory with premature loss of primary incisors before eruption of primary canines. What I'm trying to tell is the prosthesis, either fixed or removable, that we use for the primary children, for primary incisors, it is not mandatory. Why? Because it does not, whenever primary incisors are lost, when they're lost after eruption of primary canines, it does not lead to any space loss. It does not do that. So there is no need actually to go for it. The only need is the parents' preference. So now talking about the removable prosthesis, it is best suitable for loss of multiple teeth. So when there are more than 3 to 4 teeth lost, then you can go for removable prosthesis. Reason being they are small, so if there lies always a risk for the children to swallow it. So it's better to go for something which is fixed when the patient is small. And secondly, the patient will wear only if on his or her will. So you are more dependent on the patient to wear it, rather than it's not, you are not the one who's controlling the wearing of the denture. So now the Groper's appliance. The Groper's appliance, when we are considering the need for an anterior appliance to replace missing primary incisor, the following points should be discussed with the parents. First is that the strongest factor for placing an anterior aesthetic appliance is parental desire. The parental desire is the strongest factor. Space maintenance, masticatory function, speech development, and tongue habits may occur when there is loss of primary incisors, but they are not to an extent which anywhere is quoted in any of the publications or any of the journals. So there is not much considerable space loss, but yes, there can be a speech the speech disturbances or tongue habit when the loss is prior to when the child has developed speaking abilities. Then minimum space loss occurs and there is a distolingual inclination of the teeth resulting in the collapse of anterior teeth, and there can be closure of the space and midline shift, especially when the primary canines have not erupted yet. So this is how a Groper's appliance look. All you need to do is if obviously usually the child that are treated with Groper's appliance usually either are suffering from ECC, though more or less their molars are carious. If their molars are carious, you need to treat them endodontically or whatever treatment it is required, and you need to cover it with the stainless steel crowns, and then you have to solder the Nance palatal arch look like structure. It's similar to Nance palatal arch. What it has is it has little projections which holds the teeth in place, the incisors in place. This is how it looks like. So the teeth have been replaced with the Groper's appliance. You can see over here. Now coming on to a quick summary, what to be done, when to be done. If the initial reversible stage is there, you need to apply fluoride varnish or the CPP fluoride varnish. Then if the damaged caries stages, that is when enamel breakdown has occurred and dentine is visible, then you can go for restoration, STF, smart technique. It all depends upon the age of the child. Then if we have deeper lesions, the treatment needs to be done according to the diagnosis. That is, what are the indications of PULPOTOMY and PULPECTOMY needs to be considered, followed by the crown placement, whichever crown you are comfortable, doing, or the patient's pocket is comfortable in getting it done. Then lastly, we have the traumatic stage. The post and core if no root resorption is there, extraction if root resorption is present, followed by the replacement with fixed Groper's appliance or removable prosthesis. So this is the entire thing or the entire stages, entire caries which you will find in a child's mouth, and this is how you can treat it. It's a very clinically approached seminar. It's a very clinically approached presentation, and I really hope that you all have learned something today to take back something home. And lastly, what I can say is that you can, it's the world has become such violent place. There's wars every time going anywhere around the world after COVID, post COVID, Ukraine, so many things. So as Mother Teresa says, let's help in bringing peace, because peace begins with a smile. Thank you so much. Over
Those
to
are
you, Dr. Aditi.
those were some beautifully said words, ma'am. And I can assure you that each one of us is definitely taking a lot home today. And the presentation was so thoroughly explained, and the way you categorize the treatment stage wise, it made things even transparent for us. So thank you so much. We are really grateful to you. Right. And
thank you so much.
Yeah, right. And before we leave, I want to give a gist of an idea of what DCO is to our viewers. So, ma'am, if you allow.
Yes, sure.
Ma'am, you can end your screen share.
Okay.
DentistChannel.Online is the first digital dental media, and we stand strong with our motto, Healthy Smiles, Wealthy Lives. We offer multiple services for dental professionals, dental students, dental organizations, and dental businesses, starting from dental news to webinars to courses to events all around the year and multiple other things. We have hit multiple milestones with 700 live webinars being conducted with 40,000 beyond participants. We have conducted 25 plus workshops so far, and we have invited 400 plus speakers from all around the globe. There is another thing that we have etched to our golden wall. We have made our way to India Book of World Records for maximum speaker participation in any virtual dental program on oral implantology. We are most welcome to join us as our Prime members, and you can avail multiple benefits, one of which is the participation certificate for each of the webinars that we conduct. Each certificates hold one CPD or CDE point that will benefit you in the far future. You can become our Prime members by a mere sum of $799, and which will further be discounted by using my promo code AN100. And we'll soon see you again for our upcoming webinars by Dr. Pathik and Dr. Ashwin on 14th and 18th of August, respectively. You're most welcome to visit us at Facebook, Twitter, Instagram, LinkedIn, YouTube, WhatsApp, and Telegram. And we would love your engagement at our website at www.dentistchannel.online. So thank you so much. And once again, Dr. Ruhan, we are very grateful to you, and we were pleased to have you on board. Thank you so much, ma'am.
Thank you, Dr. Aditi, and thank you to this platform, which is, providing so much knowledge, open knowledge to so many people around the globe. Thank you so much.
Thank you, ma'am. Thank you. Have a good day. Bye.
You too.
So we'll end the webinar now. Thank you so much, everyone.